First question. The nurse is caring for a client with lung cancer and bone metastasis. What signs and symptoms would the nurse recognize as indications of a possible oncological emergency? Select all that apply. Here the options are facial edema in the morning, weight loss of 20 pounds or 9 kilograms in 1 month, serum calcium level of 12 milligram per deciliter, serum sodium level of 136 milligram per deciliter, serum potassium level of 3.4 milligram per deciliter, numbness and tingling of lower extremities. Let's see the options one by one. First, facial edema in the morning. Oncological patients may have blockage of blood flow to the venous system of head resulting in facial edema, and that's a sign of superior vena cava syndrome. Hence, we can say facial edema in the morning is an oncological emergency. Let's see the second option. Weight loss of 20 pounds or 9 kilograms in a month. The oncological patients do have weight reduction, but it's not considered to be an oncological emergency. Third option, serum calcium level of 12 milligram per deciliter. A serum calcium level of 12 milligram can be considered as an hypercalcemia, and hypercalcemia is considered to be an emergency for oncological patients. Let's see the next option. Serum sodium level of 136 milligram per deciliter or 136 millimole per liter. Here the sodium level is in normal limits. The next option says that serum potassium level of 3.4 milligram per deciliter, which indicates mild hypokalemia, but it's not an oncological emergency. And the last option is numbness and tingling of lower extremities. This could happen as a sign of spinal cord compression. Let's see the oncological emergencies. Sepsis, disseminated intravascular coagulation, syndrome of inappropriate antidiuretic hormone, spinal cord compression, hypercalcemia, superior vena cava syndrome, and tumor lysis syndrome. So coming back to the question, the nurse is caring for a client with lung cancer and bone metastasis. What signs and symptoms would the nurse recognize as indications of a possible oncological emergency? The answers are facial edema in the morning, serum calcium level of 12 milligram per deciliter as hypercalcemia, and numbness and tingling of lower extremities. Question number 2. A client who has been receiving radiation therapy for bladder cancer tells the nurse that it feels as if she is voiding through the vagina. The nurse interprets that the client may be experiencing which condition? Let's say the options. Rupture of the bladder, the development of a vesicovaginal fistula, extreme stress caused by the diagnosis of cancer, altered perineal sensation as a side effect of radiation therapy. Here from the question it's clear that the patient is having a diagnosis of bladder cancer and she is undergoing radiation therapy. She complains that she is experiencing passing of urine through her vagina. Let's see the options one by one. Rupture of the bladder. Here the rupture of bladder is not a condition for causing the voiding of urine through vagina. Extreme stress caused by diagnosis of cancer. The stress that is caused because of cancer may not be a reason for urine passing through the vagina. Altered perineal sensation as a side effect of radiation therapy. So if there is any sensation alteration in the perineal area may not be a reason for voiding through the vagina. Hence, option number 2, that is development of vesicovaginal fistula, could be the answer. Let's see what is vesicovaginal fistula. A vesicovaginal fistula is a genital fistula that occurs between the bladder and vagina. The fistula is an abnormal opening between these two body parts, and if this occurs, the client may experience drainage of urine through the vagina. A vesicovaginal fistula can be due to gynecological cancer, either from the disease or sometimes as a side effect of radiation therapy or surgery to treat the cancer. So coming back to the question, a client who is diagnosed with bladder cancer, receiving radiation therapy, complains that she is passing urine through vagina. Here, the nurse should interpret the condition that may be the development of a vesicovaginal fistula. Hence, the answer is option number 2, the development of a vesicovaginal fistula. Question number 3. The nurse is conducting a history and monitoring laboratory values on a client with multiple myeloma. What assessment findings should the nurse expect to note? Select all that apply. The options are pathological fracture, urinalysis positive for Bence-Jones protein, hemoglobin level of 15.5 gram per deciliter, calcium level of 8.6 milligram per deciliter, serum creatinine level of 2 milligram per deciliter. Let's see what is multiple myeloma. Multiple myeloma cells are abnormal plasma cells. It's a type of white blood cell that build up in the bone marrow and form tumors in many bones of the body. Normal plasma cells make antibodies to help the body fight against the infection and disease. As the number of multiple myeloma cells increase, more antibodies are made. This can cause the blood to thicken and keep the bone marrow from making enough healthy blood cells. Multiple myeloma cells can also damage and weaken the bone. Here in the question, the nurse has to find out the correct assessments from the options given below. Let's see one by one. First one is pathological fracture. Let's see what is pathological fracture and how it can be related to a client with multiple myeloma. Pathological fractures, especially of axial skeleton, are extremely common in patients with multiple myeloma and cluster around the time of diagnosis. It is generally believed that fractures are common in patients with multiple myeloma as a result of lytic bone lesions, generalized bone loss, and elevated bone turnover from excessive cytokine production. There is a dramatic increase in fractures around the time of diagnosis of myeloma, most of which are pathological fractures. The most common or important predictor of overall fracture risk is oral corticosteroid. Hence, option number 1, pathological fracture, must be an expected assessment finding by the nurse to be noted for a client with multiple myeloma. Here comes our second option, urinalysis positive for Bence-Jones protein. What is Bence-Jones protein test? Let's see. Bence-Jones proteins are the abnormal proteins or immunoglobulin light chains that found in the urine. A quantitative Bence-Jones protein test measures the specific level of these abnormal proteins in the urine. And these proteins are made by the plasma cells, a type of white blood cell, and are not normally present in the urine. Detection of a Bence-Jones protein may be suggestive of multiple myeloma. Hence, we can assure that the nurse has to find the assessment as urinalysis positive for Bence-Jones protein is an expected finding with the client with multiple myeloma. The third option is Hemoglobin level of 15.5 gram per deciliter. Let's see the normal range and level of hemoglobin, which varies according to the age and gender of human being. While the normal range of hemoglobin for men ranges between 13.8 to 17.2 grams per deciliter, it ranges around 12.1 to 16 grams per deciliter for women. Hence, we must say hemoglobin level of 15.5 gram per deciliter lies within the normal limits. So, the option number 3 is wrong to our question. Let's see the option number 4. Calcium level of 8.6 milligram per deciliter. We must know what is the normal calcium level. Here it goes. The total serum calcium is 8.6 to 10 milligram per deciliter. So, we can say the calcium level which is given in the option is within normal limits. Hence, the option is wrong to our question. Let's see the last option, serum creatinine level of 2 milligram per deciliter. Let's see the normal serum creatinine level. For females, it is 0.5 to 1.1 milligram per deciliter. Males, it is 0.6 to 1.2 milligram per deciliter. A serum creatinine level of 2.0 milligram per deciliter is elevated, indicating a renal problem. Renal failure can become severe and dialysis may be needed. Maintaining high urine output, that is 3 liters per day, can be very useful in preventing this complication. Hence, option number 5, that is serum creatinine level of 2 milligram per deciliter, is also an answer for this question. Here, while assessing a client with multiple myeloma, the nurse must expect the findings as option number 1, pathological fracture, option number 2, urinalysis positive for Bence-Jones protein, and fifth option, serum creatinine level of 2 milligram per deciliter. Here comes our fourth question. The nurse is teaching a client about the risk factors associated with colorectal cancer. The nurse determines that further teaching is necessary related to colorectal cancer if the client identifies which item as an associated risk factor. Options are age younger than 50 years, history of colorectal polyps, family history of colorectal cancer, chronic inflammatory bowel disease. So here the nurse has to give a further teaching to the client who identifies a wrong risk factor. Let's see what is colorectal cancer and what are the associated risk factors. Tumors of the colon and rectum are relatively common. The colorectal area, that is the colon and the rectum combined, is now the third most common site of new cancer cases and deaths. Cancer of the colon and rectum is predominantly 95% of adenocarcinoma, that is arising from the epithelial lining of the intestine. It may start as a benign polyp but may become malignant, invade and destroy normal tissues, and extend into surrounding structures. Cancer cells may break away from the primary tumor and spread to other parts of the body, most often to the liver. The exact cause of colon and rectal cancer is still unknown, but the risk factors have been identified. Let's see what all are those. The risk factors of colorectal cancer. First one is increasing age, family history of colon cancer and polyps, previous colon cancer and adenomatous polyps, history of inflammatory bowel disease, high fat, high protein with high intake of beef, low fiber diet, and the last one is genital cancer or breast cancer in women. So, to put it in a nutshell, colorectal cancer risk factors include age older than 50 years, a family history of disease, colorectal polyps, and chronic inflammatory bowel disease. Hence, the nurse has to correct the client as the age progresses, the risk increases. So, the wrong statement given as our right answer is option number 1, that is age younger than 50 years. Here comes our fifth question. The nurse is assessing the perineal wound in a client who has returned from the operating room following an abdominal perineal recession and notes urosanguineous drainage from the wound. Which nursing intervention is the most appropriate? Let's see the options. Clamp the surgical drain, change the dressing as prescribed, notify the surgeon, remove and replace the perineal packing. Here, the nurse's role is to find out the intervention which is appropriate for the patient who has undergone abdominal perineal recession and presented with serosangous drainage from the wound. Let's see what is abdominal perineal recession and why it has been done. Abdominoperineal recession completely removes the distal colon, rectum and anal sphincter complex using both anterior abdominal and perineal incisions, resulting in a permanent colostomy. In the picture, we can see the tumor prior to the surgery. Note that the tumor is in rectum. During surgery, the sigmoid is removed and colostomy is established. The distal bowel has been dissected free to a point below the pelvic peritoneum, which is sutured over the closed end of the distal sigmoid and rectum. Perineal recession includes removal of the rectum and free portion of the sigmoid from below. A perineal drain is inserted. The final result after healing. Not healed perineal wound and the permanent colostomy. Let's see the options one by one. First one, clamp the surgical drain. A surgical drain should not be clamped because this action will cause the accumulation of drainage within the tissue. Second option, change the dressing as prescribed. Immediately after the surgery, profuse serosangous drainage from the perineal wound is expected. Therefore, the nurse should change the dressing as prescribed. Notify the surgeon. The nurse does not need to notify the surgeon at this time. Remove and replace the perineal packing. Drains and packings are removed gradually over a period of 5 to 7 days as prescribed. The nurse should not remove the perineal packing. So coming back to the question, which nursing intervention is the most appropriate one? Yes, change the dressing as prescribed is the answer. Sixth question, the nurse is reviewing the history of a client with bladder cancer. The nurse expects to note documentation of which most common sign or symptom of this type of cancer. The options are dysuria, hematuria, urgency on urination, frequency of urination. Bladder tumors usually arise at the base of the bladder and involve the urethral orifice and bladder neck. Cancer of the urinary bladder is more common in people aged 50 to 70 years. It affects men more than women at 3:1 ratio. There are two forms of bladder cancer, superficial, which tends to recur, and invasive. About 80 to 90% of all bladder cancers are transitional, which means they arise from the transitional cells of the bladder. The remaining types of tumors are squamous cells and adenocarcinoma. Let's see the signs and symptoms of bladder cancer. Blood in urine, it's also known as hematuria. Painful and frequent urination. Pain in bones. Loss of appetite. Fatigue or tiredness. Swelling in the foot. Difficulty and burning sensation while passing urine. Urinary incontinence. Pain in back and abdomen. And finally, loss of weight. So coming back to the question, what could be the most common sign or symptom of this type of cancer? That means bladder cancer. The most common sign in clients with cancer of bladder is hematuria. The client also may experience irritative voiding symptoms such as frequency, urgency and dysuria. And these symptoms often are associated with carcinoma in sight. Dysuria, urgency and frequency of urination are also symptoms of a bladder infection. But in the question, they ask about the most common sign or symptom of the bladder cancer. So we must say hematuria. Question number 7. The nurse is assessing a client who has a new ureterostomy. Which statement by the client indicates the need for more education about urinary stoma care? The options are: I change my pouch every week. I change the appliance in the morning. I empty the urinary collection bag when it is 2/3 full. When I am in shower, I direct the flow of water away from my stoma. Here, the client has given a wrong statement and we need to choose it from the options given. Before going into the details of the client's statement, let's see what is ureterostomy. Ureterostomy is also known as cutaneous ureterostomy. The surgeon brings the detached ureter through the abdominal wall and attaches to an opening in the skin. The urinary collection bag should be changed when it is 1/3 full to prevent pulling of the appliance and leakage. The remaining options identify correct statements about the care of a urinary stoma. Hence, our answer, that is a wrong statement given by the patient, is the third option. That is, I empty the urinary collection bag when it is 2/3 full. It should be emptied when it is 1/3 full.